Systemic arterial supply to the lung can be part of the so-called scimitar syndrome. A better term is a hypogenetic lung syndrome. Scimitar is an Arab sword, and the abnormal vessel that we see usually in the right cardiodiaphragmatic angle, and most of the time it represents a vein, can be also an artery or a combination of both, is only part of the syndrome that also involves anomalies of the pulmonary arterial supply to the hypogenetic lung, as well as anomalies of the tracheobronchial tree. So a better term is the hypogenetic lung syndrome, and Dr. Felsen used to call it the venolobar syndrome. There's more than veins and more than the lobe that is abnormal. So here is a frontal view of the chest that shows a dextrocardia with dextral rotation of the heart. Note that the right lung is somewhat oligemic. This pulmonary angiogram shows that the right pulmonary arteries are normal, except that the medial aspect of the right base is not supplied by pulmonary arteries. In the venous face of the angiographic examination, we see normal left pulmonary veins, a normal left atrium, normal left ventricle, and aorta. However, from the distal aorta, we faintly see a vessel that is directed towards the right base. The distinct abnormality is a large vein that runs parallel to the right heart border and traverses the diaphragm. In this close-up, we can see that this abnormal vein drains in the inferior vena cava. So therefore, a left to right shunt occurs due to mixing of oxygenated blood in the pulmonary vein draining into unoxygenated blood in the inferior vena cava. This is another view which reveals the large vein of the hypogenetic right lung, filling the cava and the filling of the right. An aortogram shows a large artery that is directed towards the right base. So we can say that the abnormal vessels that are noted in the medial aspect of the right lung are usually dilated pulmonary veins that drain abnormally below the diaphragm, and some of the markings are due to the systemic arteries, which may arise from the distal abdominal aorta, celiac trunk, proximal abdominal aorta, and even the phrenic arteries. This is a frontal view showing some dextro position of the heart with indistinctness of the right heart border. That should make one suspect that there is either middle lobe disease or that there is a hypoplastic middle lobe with a fat next to the right heart border. The left lung appears hyperexpanded, the right lung is hypo. A close-up of the right hemithorax shows a large draining vein that bisects the angle between the right heart border and the diaphragm. Note that there is a blunting of the right costodiaphragmatic. A lateral view of the chest shows evidence of a hypoplastic right lung. Note that the anterior edge of the right lung is well seen, crossing the shadow of the heart. In front of the hypoplastic right lung, we see a haziness due to the heart, as well as fibroadipose tissue interposed between the hypoplastic right lung and the sternum. CT can be used to demonstrate the abnormal venous connection as seen in this. This is a hypogenetic lung syndrome where there was evidence of dextral position of the heart, a hypoplastic right lung, and an anomaly in the bronchial tree. Note that some branches of the right main bronchus are missing due to aplasia of the airway. In a pulmonary angiogram, we can see the dextro-rotated heart and dextral position of the heart. We know that normal left pulmonary vascular tree And in the venous phase, we can see draining veins that are directed towards the abdomen and represent the abnormal pulmonary venous connection or abnormal pulmonary venous drainage of the hypoplastic right lung. This is a cast corrosion of the right lung showing a diverticulum of the right main bronchus. In addition to hypoplasia or aplasia of some lobes, we may see also a bronchial diverticulum. And in blue, one can see the draining vein that is noted in the medial aspect of the right lower zone. This is a lateral view of this cast corrosion preparation showing the abnormally draining veins, and this patient also had systemic arteries that supplied the hypogenetic right lung. In this bronchogram, we can see a hypogenetic right lung with the scimitar syndrome, the abnormally draining vein of the right lung bisects the angle between the heart and the right dome of the diaphragm. And again, the indistinctness of the right heart border is due to fat that fills the space between the hypogenetic lung and the chest wall. This patient had abnormal markings in the right lower lobe. Note that they are directed towards the costodiaphragmatic angle posteriorly, as seen in the lateral view of the chest. In the tomogram, in the lateral projection and frontal projection, we can see two findings. One is a vessel that is bisecting the right cardiodiaphragmatic angle, and we can see in the penetrated image the draining vein of the right lower lobe. At this time, the diagnosis was made of bronchopulmonary sequestration. A pulmonary angiogram revealed that the pulmonary artery did not perfuse this area of the lung, and in the arterial phase, we can see that there is an artery that feeds the right base, but that the right lower lobe pulmonary veins normally drain towards the left atrium. A cast corrosion preparation showed that this patient had a systemic arterial supply to the right lower lobe without bronchopulmonary sequestration, and the tracheobronchial tree appeared absolutely normal. So this is an unusual example of systemic arterial supply to the lung without the bronchopulmonary sequestration. And in this case, the so-called scimitar-like finding is due not to an abnormally draining vein, but to large arteries that come off the distal descending proximal abdominal aorta, celiac trunk, or right phrenic artery. This is from the book of Keith, Wagenvort, and Edwards, showing the various forms of systemic arterial supply to the lung, and they can be seen with or without the bronchopulmonary sequestration.